Bismillah ar-Rahman ar-Rahim. Our lecture today is epilepsy. Epilepsy is a group of disorder characterized by a clear tendency of recurrence of unprovoked seizure occurring at least 24 hours apart. So we need recurrence, more than one, and to be unprovoked, and the recurrence should be 24 hours apart. These three factors should be found in seizure to labeled as epilepsy. It is a stereotype for individual patient. Each patient have, it's similar. Each attack is similar to each one. Epidemiology of epilepsy. Epilepsy is a common problem. The incidence of epilepsy is 0.4 to 0.5% all over the globe. The prevalence estimated at 0.5 to 1%. This is very high, with higher rate among infants and older than 60 years of age. Remember something very important, that the chance of having a single seizure is between 5 to 10%, is very high. The prevalence in developing countries like our country is 5 times higher than developed country. The incidence is double. There is some terminology. We should know it before discuss the detail about the epilepsy. What is the seizure, which should be recurrent to diagnose epilepsy? Seizure is a transient disturbance of cerebral function caused by abnormal neuronal discharge, characterized by excessive over-synchronized discharge of cerebral neuron. Clinically, seizure could be motor, sensory, autonomic, or psychic phenomena. As we mentioned in second lecture, manifestation in neurology divided into positive and negative. Seizure is a positive phenomena. Single seizure, as far as the patient have single seizure, we cannot label him as epilepsy, but single seizure is an indication for investigation. We have several terms should be known, used in discussion of epilepsy. What is thoughts paralysis? This is the negative phenomena which happen after the positive phenomena, which is the ictus. Status epilepticus is very important to know because the treatment is completely different from the usual epilepsy. Status epilepticus is a continuous seizure lasts beyond 5 minutes, or repetitive seizure with fall of consciousness is not restored between successive episodes. Epilepsy partialis continua is a focal motor status epilepticus. We have a term which called epilepsy syndrome. What is epilepsy syndrome? Especially used in describe epilepsy in pediatric age group. Epilepsy syndrome is a complex of signs and symptoms that define a unique disorder in which epilepsy is a predominant feature with distinctive EEG pattern or associated with a neurological abnormality. The syndrome are often age-specific and the treatment is depend on the determination of the type of the syndrome. Epilepsy syndromes may be symptomatic, that the cause is obvious, or idiopathic. And as you know, idiopathic, it doesn't mean there is no cause, but we don't know the cause. And nowadays, primary etiology is believed to be genetics. What is the basic mechanism? How a seizure is formed? Basically, we have a focus that the discharge happened. But you should know there is a balance between excitation and inhibition. And the cerebral cortex, the function of cerebral 70% of the function of cerebral cortex is inhibition. So we need a focus. This focus excited a discharge that it is an initiation, but the initiation needs a propagation. The initiation phase have characterized by two concurrent events in an aggregate of a neuron. High frequency bursts of action potential need to be hypersynchronization for existence of the seizure. The focal discharge remain localized. Okay, even the burst hypersynchronized and seizure will exist in this area. It will be focal, but how the focal discharge become generalized? It should be transmitted through commercial pathway between both cerebral cortex. If it passed through the commercial pathway and diffused bilaterally, it becomes what we labeled is as what we call it as focal epilepsy with secondary generalization. But we have a primary generalized seizure. So how this happened, how it become generalized from the start? There is no explanation other than this focus is from the diencephalic activating system, which could be discharge diffusely, bilateral diffusely to the cortex. The etiology. Why we insist to determine the etiology? Unfortunately, 2/3 of the patient with epilepsy is the cause is idiopathic, but still the treatment of epilepsy is basically to treat the cause rather than the seizure itself. So etiology of seizure can be classified into idiopathic, which is 2/3 of the patient, symptomatic, clear cause, and cryptogenic. Cryptogenic seizure occurring without a known cause, but presumably not idiopathic because of associated neurological and developmental abnormality. There is a clear abnormality, but we didn't determine the cause. So we labeled as a cryptogenic rather than idiopathic. Idiopathic, we have no assumed cause, but here we have something to give hint for the cause, but we didn't reach the cause. The causes of seizure divided into two types, provocative and epileptogenic. And remember, the definition of epilepsy is recurrence of unprovoked seizure. So when we detect a provocative factor, we will exclude this patient from the definition of epilepsy. We divided the causes into provocative and epileptogenic, but there is no clear cut between both two. There is some overlapping, but clinically we can determine that the causes as a result of from either from central nervous system dysfunction or underlying metabolic derangement or systemic disease. So, as we said, first, when we detect the cause, we should decide, is this cause is a provocative or unprovocative? Because, as we said, unprovocative cause, whatever the recurrence, the number of recurrence, it is not epilepsy. Epileptogenic factor is, we have high concern for epileptogenic factor because in one seizure, if the patient with epileptogenic factor, with one seizure, there is high tendency for recurrence. So, with epileptogenic cause, there is liable to be an epilepsy, even we cannot label the patient as epilepsy so far. Epileptogenesis refers to the transformation of normal neuronal network into one that chronically hyper-excitable. What is a provocative factor? What is epileptogenic factor? Simply, provocative factor is non-structural. Epileptogenic factor is structural. Any cause, if we detect the cause, we should decide, is this cause is structural or not? The problem is some causes could be structural, could be non-structural, and we should decide. We should personalize the issue and decide on the bedside. Provocative seizure accounts for about 40% of first-time seizure. Approximately 40 to 50% of individuals who suffer from unprovoked first-time seizure will experience recurrence. But the recurrence cannot put him under title epilepsy. What is the primary neurological disorder that can cause epilepsy? Still, idiopathic is the top of the list, but the other conditions rather than disease, like stroke, mass lesion, head trauma, meningitis, encephalitis, and nowadays there is an entity called autoimmune epilepsies, and autoimmune epilepsy should be considered in any patient with intractable epilepsy. And later on, we will discuss what we mean by intractable epilepsy. Any patient unresponding to treatment, we should consider the autoimmune epilepsies. Systemic disease, which is highly considered as provocative factors, but not always. Remember, is metabolic disorder, hyperthermia, hyperperfusion syndromes, اللي هي hypertensive encephalopathy, and eclampsia. In these cases, the patient not considered to have epilepsy. Mainly, usually, these three, any metabolic disturbance should be corrected and no need for anti-epileptic. Any cause of hyperthermia should be corrected and with no need for starting anti-epileptic. Hyperperfusion syndrome like eclampsia and hypertensive, the same. The classification of seizure. There is a classification of seizures we can depend on to choose the anti-epileptic drug when it is indicated. Generalized seizure with tonic-clonic, absence, myoclonic, and tonic-clonic, atonic. Partial or focal, the same meaning, which is simple partial, complex partial, partial with secondary generalization. Choosing of anti-epileptic in partial with secondary generalization is the same for simple partial. In generalized, it's something different. Unknown onset, like motor, non-motor, and unclassified. Epilepsy syndrome, we have two examples, which is important to be known in your level. The febrile convulsion, I think most of you know what is febrile convulsion from studying pediatric problems, and reflex epilepsy. Febrile convulsion of childhood are seizures that occur during the first day of febrile illness, and in the absence of central nervous system infection. Seizure usually between 3 months and 5 years of age, and have peak incidence between 18 months and 24 months. Febrile convulsion divided in two types: simple febrile seizure and complex febrile seizure. The old name was febrile convulsion, but nowadays they used, I put these two because there's no general agreement about each one of them separately. Simple febrile seizure is not associated with possibility to have epilepsy later on, but complex febrile seizure, which differentiated by its duration and the recurrence, have the highly probable visual, auditory, somatosensory, writing and reading, eating. The most common one is the visual. Here, the reflex epilepsy is almost always associated with this stimulus. It's different from what we know about epilepsy that precipitate by visual, like television. Many doctors recommend to restrict or even prevent the child to watch TV or computer or something like that because of possibility of reflex. It is not practical. Cannot be allowed. If we consider reflex epilepsy in each patient, so any patient with eating reflex epilepsy should be prevented from eat. Is this logical? It is rare and should be considered, and give a treatment to make the child live in normalcy.
دكتور
ثاني
دكتور زين، يعني هسه هو هذا شلون راح يصير الاستيميليشن؟ يعني مثلا تقول eating او writing، يعني شلون
هذا يعني هو almost always with مثلا الفيجوال with watching TV، يلعب بالتاب مثلا. with eating هذا almost always هو يبدي ياكل يصير عده، هو يسمع صوت معين زين يصير عده، مثلا شويه صوت العالي يصيحون عليه راسا صارت عده. هذا الريفلكس. ومرات مره بلبنان كيس ما ادري شلون عندهم فتشي مثل التونجا فتشي لبناني، هذا كل ما يريد يشرب بيها تصير عده، هو بالريف فتشي، يعني almost always associated with this stimulus. زين this is very rare but we should consider and differentiated from the usual. هو طبعا الاذر ستيمولس رير، لكنه بالفيجوال، لان الفيجوال هي precipitating factors sometimes for usual seizure. How do we approach the patient with suspicion of epilepsy? History. For evaluating epileptic patient, the following question should be answered. Is what are dealing with is epilepsy or something else? If it is epilepsy, what type of epilepsy is it? Because the treatment depends on the type. What is the cause of epilepsy? Because primarily the treatment toward the cause rather than to give anti-epileptic. When do you suspect seizure? I like this question. Every patient with time-limited loss of consciousness. Every patient with time-limited neurological manifestation. And any patient with unexplained incontinence. طفل عمره 10 سنين حياته طبيعية، واحد قاعد الصبح بايد بفراشه. You should suspect that the patient has seizure during sleep. The question should be focused on the symptom before, during, and after the episode in order to discriminate a seizure from other paroxysmal events. This episodic phenomena, we should ask about what happened before. We called it aura, although aura nowadays is not used in high extent, because aura now considered as focal epilepsy rather than different phenomena. What is the duration? Because it's time limited. What is the clinical phenomenology? Is it motor, sensory, autonomic, psychic? Stereotypy, and this is very important. Each attack is all the attack is similar to each one. Loss of consciousness, the post-ictal confusional state. After the finishing of the convulsion, if it is motor, there is an area with the disturbance of consciousness, content of consciousness. Thoughts paralysis, the negative phenomena post the ictus. Any associated signs of symptoms such as loss of bowel or bladder control or tongue biting. It is if we determine the seizure and we decide this is seizure in history, we should also focus in the provocative factor, epileptogenic factors, provocative factors, epileptogenic factors, risk factors, precipitating factors, and comorbidities. Provocative factors and epileptogenic factor, I think we discussed that. It's very important. In patient with epileptogenic factors is liable for recurrence. Provocative is no need for treatment and not labeled primarily as a case of epilepsy. Risk factor is useful to know that the patient more liable to have epilepsy, like family history. Precipitating factors is important in breakthrough. The patient is controlled. خصوصا هسه احنا يعني خلصنا رمضان. The patient is controlled for more than 6 months with the good compliance treatment, and there's no more attack. But in one day, he developed 5 to 6 attacks. In this time, you cannot say this is failure of a treatment, because why he was controlled in the last 6 months. Try to find the precipitating factors. طبعا برمضان هاي تصير دائما يصوم، والصيام عندنا اكثر من 12 ساعه، يتاخر الدواء، هو الصيام نفسه precipitating factor. Fasting is a precipitating factor. And خلي المريض يفطر يرجع طبيعي على same dose. مع الاسف in our society, any new attack usually the physician change the treatment, and changing the treatment is not only unwanted but may be dangerous. The patient is controlled. Why we change the treatment? Comorbidity is very important to consider in any patient with epilepsy for many factors. First one, the choice of anti-epileptic should be useful, or at least not harmful for the other disease. And we should remember there is something called interaction between drugs, and the patient with other comorbidity may have other drug that interacted with anti-epileptic. An examination, usually the examination, the epilepsy diagnosed by history. Examination, if there is any physical sign, it will be help to determine the cause rather than to diagnose epilepsy itself. Investigation. EEG. The EEG, electroencephalography, is not sensitive the standard EEG is not sensitive in epilepsy. So it's not highly useful. It's not the positive EEG is no more than 5%. So it's not a mandatory to send EEG in any patient with epilepsy, and there is indication for that. To increase the sensitivity of EEG, there is another tool, which is prolonged video EEG monitoring, sleep EEG, EEG with special electrode, foramen ovale, subdural, ambulatory EEG, video telemetry. There is these tools to increase the sensitivity of EEG. Inclusion of photic stimulation, hyperventilation, sleep deprivation in adult is part of the protocol to increase the sensitivity of EEG. Other investigation is to detect the causes of the causes of the epilepsy. And we send level of drug in the blood to monitor the anti-epileptic treatment. Now, what is the treatment and the principle of a treatment in patient with epilepsy? There is basic goals of a treatment for epilepsy. It helps the patient to achieve freedom from further seizure without adverse effect of therapies, or at least minimize the frequency of disabling and potentially injurious seizure type when seizure freedom is not achieved, and to address any relevant intellectual comorbidity of epilepsy to maximize the quality of life for people with epilepsy. Usually most of the patients responding in treatment have a normal high maximum quality of life, but in 20% of the patient, the goal is to minimize the impact of epilepsy on the patient. As I said, therapy should be directed toward the cause of the seizure, if no, as much as we can, except in status epilepticus. When we label the patient status epilepticus, everything is changed, and primarily we should be directed to stop the seizure rather than to find whatever the cause. And we didn't search even for the cause. Stop the treatment and later on search for the cause. Any recurrent seizure do require anti-epileptic treatment, no doubt. But if the patient presented with single seizure, in single seizure, we cannot label him as epilepsy, because the definition of epilepsy, as I said, is recurrence of unprovoked seizure. So this patient presented with no recurrence, but is this patient part of those people, 5 to 10% who have single seizure during his life, or it is only the first seizure? And maybe the second seizure will be status, and the status have mortality of 20%. So which patient is a first seizure and which patient is the patient with single seizure? We have a factors that if it is found, he have liable to have recurrence. Age over 60. Any patient with age over 60 should be considered as a case of epilepsy, even he have no recurrence. Post-ictal thoughts paralysis, the possibility of recurrence is very high in this. Any patient with epileptogenic factor, any patient presented first time with the status epilepticus, any patient with single seizure with EEG abnormality, any patient with seizure during sleep, because sleep is during sleep the brain is quiet. If in quiet period he develops seizure, definitely he will develop seizure during daytime in the future. History of complex febrile seizure, family history of epilepsy. But remember, I don't say give the treatment for any patient who's liable for recurrence, because many patients with family history of epilepsy will develop single seizure during his life and with no recurrence. anti-epileptic drug treatment. If we decide to start anti-epileptic, we should remember that first, the mechanism of action. Effective seizure treatment generally augments inhibitory process or oppose the excitatory process. As we said, seizure is a balance between excitation and inhibition. So the treatment either increase inhibition or decrease excitation. The decision to initiate anti-epileptic drug therapy based on careful consideration of risk of recurrence. يعني بس اقول لكم انه اول ما سوى بانجلترا epilepsy clinic وبدا referral for epilepsy clinic, they found that 25% of patients on anti-epileptic treatment is not epileptic. And remember, anti-epileptic treatment is continue for at least 2 years. So here we'll have all the side effects, all the interaction with other drugs if it is if he received other drugs, and there is no indication, no real indication for anti-epileptic. قيسوا قد عندنا من الناس اللي ياخذون anti-epileptic with no indication. And in our society, the combination of anti-epileptic is high and with no need for that. So we got a careful consideration of risk of seizure recurrence. If there is no seizure or no risk of recurrence, no need for treatment. And risk-benefit ratio for available treatments. We have many treatments, but we should evaluate the risk-benefit ratio for available treatment option. Special consideration must be given to populations such as women, older adult, patient with other medical comorbidity, and patient with first seizure. Women, not only pregnant women, but women in general, and women especially in childbearing age, because maybe she's on anti-epileptic and become pregnant and with teratogenicity. Don't give this chance, please. There are three principles of management. Yeah, we talk about the ideal how to deal with the anti-epileptic treatment ideally, but this is the principle, the action. Establish the diagnosis of epilepsy before starting drug therapy. Maybe you will see it as this is logic, this is basic. Why you insist for that? Because in our society, anti-epileptic started without a clear diagnosis of epilepsy, only suspicion. Choose the right drug for the seizure type. This is not only choosing between which is better. No. Some anti-epileptic drug is harmful for types of epilepsy. We may choose an wrong choice of anti-epileptic drug for this patient may aggravate his condition or her condition. So choose the right drug is to give the benefit rather than the hazard to the patient. Evaluate one drug at a time, because 70% of the patient with epilepsy responding only to one drug. And the need of treatment of more than one drug is no more than 5 to 10%. The other is intractable and need surgical interference. Anti-epileptic drug treatment, there is many factors to choose the anti-epileptic drug. We said in second point, the right drug. How do we choose the right drug? We should know there is, we need a background information about each drug and each patient. Epilepsy classification, anti-epileptic mechanism of action, anti-epileptic drug side effect profile, and the drug interaction. Monotherapy. Start with one drug. Monotherapy. Monotherapy, then polytherapy. Monotherapy. Monotherapy, then polytherapy. Start low and go slow. Start with the minimal dose and increment. You should have a schedule of increments slowly. Every 2 weeks. If there is no response, increase the dose. Increase the dose very slowly, very slow. Drug withdrawal. After control of epilepsy, drug withdrawal should be started 2 to 5 years after the control. 2 to 5 years. Which patient we will choose 2 years, and which patient let him to continue for 5 years. If there is risk factor for recurrence, complete the 5 years. سلايد واضح؟
نعم دكتور.
ماشي.
نعم.
اوكي. بسم الله الرحمن الرحيم. Okay, which patient we choose the minimal period and which patient have take the maximum? If there is risk of recurrence, we choose the maximum. Any patient with abnormal EEG, for example, when a patient with epilepsy continue 2 years free of seizure, I will send to EEG. If the EEG is abnormal, my recommendation is to continue for more 1 year. After 1 year, I repeat the EEG. If it is abnormal, I will repeat it after 1 year to reach the maximum 5 years. At 5 years, no need to do a new EEG and start withdraw of anti-epileptic drug. Any patient with cerebral structural abnormality, just like a history of a tumor, for example, benign tumor, which can be operated on and the patient doing well, but don't take the maximum period and no need for new EEG. Please remember, withdrawal of anti-epileptic drug going on very slow. When we start low and go slow, and withdrawal also we go very slow and take at least 3 to 6 months to reach to stop the treatment. There is an issue which is highly concerned in patient with epilepsy. If the patient presented with single seizure, shall we start the treatment or wait for the second seizure? And remember, maybe the patient with 5 to 10% of normal population who have only 1 seizure during their life. Or if we wait for the second seizure. Second seizure may be status epilepticus, and status epilepticus have mortality more than 20%. So what we can do in this situation? There is recurrence, and there is criteria. Maybe not don't have we didn't have an agreement all over the world about this recommendation, but it have high agreement that it should be followed. Any patient with one epileptogenic factor, we should start anti-epileptic with single seizure. Any patient with single seizure and EEG abnormality, we should start. Any patient with single seizure that is nocturnal should start. Any patient above age of 60 because of the atrophy, the liability of microinfarction in those patients, we should start. Two other risk factors, like history of complex febrile seizure and family history of seizure. So any patient with history of complex febrile seizure is not enough to start anti-epileptic if he develops single seizure. One risk factor and patient preference. What do you mean by patient preference? A patient is a driver. If he develop any driver develop epilepsy, should be omit his job, and it's very disaster situation. So I'm one risk factor within this patient. We should start anti-epileptic to prevent the second one or the possibility of second one, just to make his life continue normally. And a breakthrough seizure, if the patient is controlled for at least 6 to 1 month and everything's going well, and the patient doing his daily life activity normally, and he developed multiple seizures in one time, in this patient, we called it a breakthrough. We should search for a precipitating factor rather than to increase the dose or change the drug. It cannot be labeled as failure of a treatment anymore. But what is the precipitating factor for that? For example, يعني احنا الحمد لله خلصنا رمضان. This is usually in fasting. Patient normal for about 1 year وخلاص شاف نفسه زين. You want to يعني يريد يصوم زين, and he developed 4 attacks within 1 day. Don't change the dose, don't change the drug. Only ask him to eat, to stop fasting, and that's it. Type of epilepsy, and according to the type of epilepsy, there is first line and second line. I don't care about second line in your level, because first line is your job in the future. And wrong choice make the specialist difficult to change. So you should know what is the first line for each type of epilepsy. This is the job of the general practitioner. And you'll do it in the first few years of your career before you become a specialist. So it's very important, because the first drug is the job of general practitioner, which is difficult to change later on. And combination of drugs in failure of monotherapy, I say monotherapy, then polytherapy. Polytherapy, please refer him to the specialist. This is not a job of the general practitioner. In summary, start treatment in recurrence unprovoked seizure. This is the definition. Single seizure with high risk of recurrence. recurrent reflex epilepsy. يعني لا تقول مو هذا reflex يعني بيصير only I know this the provocative factor, but in reflex epilepsy, this rare type, the recurrence needs treatment. What is refractory seizure? And the treatment of refractory seizure need polytherapy. Approximately 70% of persons with epilepsy gain a state of long-term seizure control. 70% احنا خلصانين من عندهم. But we have 30% which is pharmacoresistant epilepsy. By definition, failure of adequate trial of two tolerated, appropriately chosen, not wrongly chosen, وتسميها intractable, and used anti-epilepticus scheduled alone or in combination and at the highest dose the patient can tolerate to achieve sustained seizure freedom. سويت كل اللي عليه. بديت للمونوثيرابي. زين. This patient have maximum dose of appropriate chosen drug. We labeled him as intractable epilepsy. In intractable epilepsy, we referred him to the surgeon. But before send him to the surgeon, maybe, okay, this is the definition of intractable epilepsy or pharmacoresistant. But remember, there is something called pseudo-resistant. And before send the patient to the surgeon, remember to exclude pseudo-resistant. يعني أنا هاي اللي يعني ما أدري والله المضحك المبكي عندنا. Wrong diagnosis هو وصل للمالتيبل polytherapy multiple drugs والنتيجة أنه he's not epileptic. Wrong drug, wrong dose, poor compliance. وpoor compliance يعني حقيقة يعني this is what written in the literatures and in the books أن يخلون wrong diagnosis, wrong drug, wrong dose, poor compliance. In our society, in our circumstances, poor compliance is the top of the list. مريضنا ما يلتزم. يعني لو سوينا incidents للسودو resistant بالعراق, definitely poor compliance at the top of the list. Wrong diagnosis, wrong drug, wrong dose. نعم نتذكرها, اكو يجونا هالمرضى. wrong drug, الدوز دائما اندر دوز, المريض مصر لا انا اعطوني هذا قال لي الطبيب الاول تريتمنت هالقد, انا خلاص ما غير مو انت ماذا تستفاد, لازم نزيد مصر. اوكي. But poor compliance at the top of the list. زين. What is the surgical treatment available for treatment of intractable epilepsy? First, surgical excision. نشيلها. Or vagal nerve stimulation. This is a stimulation of the vagus nerve. Stimulation of the vagus nerve found to be useful in stop treatment. But this is not a magic maneuver. This is only, they say it is better than to start a fourth drug. Intractable epilepsy, by definition, is too appropriate maximum dose drug. Vagal nerve stimulation is better than the fourth drug. يعني حتى بديت للثالث intractable وهم استفاد تبدي vagal nerve stimulation is indicated, but it's not a magic. Remember that. Treatment of status epilepticus. If, as we said, everything is changed now, and the goal is directed to the stop treatment because the damage to the brain will be started 30 minutes after the onset of status epilepticus. So The measures to stop anti-epileptic first start with ABC. Any patient with disturbance of consciousness, give dextrose and thiamine for like in any patient with disturbance of consciousness, and start drug treatment first 20 minutes of a presentation. First 20 minutes. أول ما يوصلك minute تحسب. First 20 minutes you give short acting. Then if the seizure not stop, the next 20 to 60 minutes, next 40 minutes, يعني من الدقيقة 20 presentation to الدقيقة 60 start long acting treatment اللي الفينيتون فوسفينيتون and valproic acid phenobarb. After 1 hour we call it a refractory status epilepticus and refer the patient to respiratory care unit to start anesthetic drug and put the patient on the ventilator because of using of muscle relaxant. Muscle relaxant is not anti-epileptic, but the after 1 hour the aim will be to stop convulsion rather than to stop the seizure, and make this to get rid of the side effect of the hazard impact of the status epilepticus. Put the patient on the ventilator for 24 hours and start withdraw, weaning of the drug and weaning from the ventilator. After that, if there is no response, we label the patient as super refractory. In super refractory, we start the treatment in the first and second stage, and start and think now in autoimmune epilepsy and give a treatment with for that condition. Usually I start with methylprednisolone. 50% of the patient was super refractory. طبعا 20% of status epilepticus died. 50% of patient was super refractory اللي تقضي عليهم 24 ساعة non stop died. There is an entity called non-convulsive status epilepticus. What is non-convulsive status epilepticus? And before 15 years and more, when we give the lecture about stopping status epilepticus accepted anymore. Any patient not improve within 20 minutes or normalized within 60 minutes after convulsion stop, labeled as non-convulsive status epilepticus. It means that this patient, the convulsion is stopped, but the seizure is continue, and he continue need a treatment because the status is continuous. The status epilepticus is continuous. What is the side effect of anti-epileptic drug? In general, all anti-epileptic drug may lead to blood dyscrasia. So monitoring of blood count is mandatory. Most of anti-epileptic drug is affected the cognitive function in some degree. So we have a high level of concern about starting anti-epileptic drug in geriatric age group. In a pregnancy, no anti-epileptic drug can be considered to be absolutely safe. No one, but relatively safe. For example, carbamazepine, relatively safe. And some is relatively more teratogenic, like valproic acid. So valproic acid usually not started in any childbearing female. In elderly is more liable for side effect. So you should monitor cognitive function and alertness, gait stability in يعني have particular concern. What is the prognosis? Patients with epilepsy have a risk of death that is roughly 2 to 3 times more than normal population. There is something called sudden unexpected death in epileptic patients during sleep. This is usually due to seizure developed during sleep. So control of epilepsy is highly recommended. The last subject is pseudo seizure. We have conversion disorder, factitious disorder, and malingering. The difference between these three is the production of the seizure, of the how to simulate the seizure, and motivation. In conversion disorder, he's not product the seizure, and you have no motivation for that. The hysterical person. In factitious, he do it, and he know he do it, and he know he have the will to do it, but he don't know the motivation for that. Malingering, المدعي, no, he do it, and he know why he do it. هاي كنا نشوفها من ايام زمان يعني يريدون ياخذون جايز. زين، يدعي السيجر ويعني موتيفيشن يريد اجازه ويسويها مضبوط، يعني simulate the seizure. So you should differentiate. And thank you. ان شاء الله طريقكم دائما اخضر. من عنده سؤال عيني؟ ومتأسف على اللي صار اليوم القطع يعني. ماكو سؤال؟
دكتور إذا أكو provocative factor يعني هاي بعد ما نقدر نسميها epilepsy مو؟
لا never.
زين دكتور، من ضمن الميتابوليك الهايبومغنيسيميا ممكن تسويه؟
كلها. هايبومغنيسيميا والله يعني اذا تسوي فهي رير، بس هي ميتابوليك ديرنجمنت ما اقدر اجاوبك عيني.
تمام.
اي دونت نو. اي ما ادري والله. اي شو يعني باي ديفينيشن نقول احنا unprovoked it mean no provocative factor, no more than that. هي مو اكو causes of unprovoked، هي اكو provoked واكو epileptogenic. unprovoked هي انه ماكو provoked، only that. يعني our concern to know the provocative factor. If it is absent we called it unprovoked. ماكو بعد سؤال عيني؟ اوكي عيني، شوفكم ان شاء الله مستقبلا يعني. المحاضرة الجاية دكتور عبد الكريم ان شاء الله يوم الاحد. نشوفكم بخير عيني. خذوا راحتكم.